Now, moving on to our first section, that is the assessment, examination, and management of thoracolumbar spine injuries. Firstly, the pathogenesis and the mechanism of injury. Now, when you see thoracolumbar spine injuries, you know there are 12 thoracic vertebrae, although it can occur anywhere, and there are 5 lumbar vertebrae, as it can be seen it over here: L1, L2, L3, L4, and L5. But what is the most common area is of injury of thoracolumbar spine? That is the thoracolumbar junction. And why? Because these most commonly injuries occur from T11 till L2, and mostly it is at the T12 L1 junction. The reason is there is actually a transition going on at this time. Thoracic vertebrae are relatively more mobile as they are attached to the ribs, and during inspiration and expiration they have to move. Therefore, they are relatively more mobile, and the lumbar vertebrae are relatively more rigid or more fixed. Therefore, when there is acceleration or deceleration injury, there is actually increased movement of thoracic spine, but there is less degree of movement on lumbar spine, and this results in the thoracolumbar junction being mostly the cause of the injury, and mostly over this area, because there is the relative motion of one segment of spine to the other is actually creating a force which actually results in a distraction flexion type of an injury. Upper 3/4 is actually protected by rib cage. That is why you have less common fractures of thoracic spine, because initially this may be associated with thoracic injuries and life-threatening thoracic injuries, pneumothorax, hemothorax may be associated with rib fractures, and rarely you have a upper 3/4 of fractures of a thoracic spine. Mainly, if these fractures are mechanically stable, if they do occur, and spinal cord is relatively narrow as well. Now, lower nerve roots are more at risk, especially with the lumbar spine. And why? Because at this level there is actually transitional, relatively the spine is more rigid, it's going to take more brunt of the force, and therefore results in more of a fracture and leading to increased canal compromise and increased nerve root compression. Now, pathogenesis. If there is a low energy insufficiency fracture means there is a very trivial trauma, and usually the bones are actually weak. They're morely associated with osteoporotic females arising from comparatively mild compression stresses in an osteoporotic bone. Minor fractures of the vertebra usually due to compressive tensile or torsion strains. Now, what type of fractures occur is actually dependent upon the mechanism of force which is actually acting on the spinal cord. This could be an axial loading leading to compression type of fracture. This could be axial loading followed up by translation. It could be, most commonly it is the flexion distraction type, in which actually there could be a ligamentous disruption of the posterior ligamentous complex or the tension band, which is actually acting as a tension band all for the vertebrae. Or there could be osseous ligamentous disruption as well, or it could be simply translational or rotational element as well. Translation and rotation can occur in the sagittal plane, that is you can appreciate it on the lateral view, or this could occur in the coronal plane as well, which is more visible on the AP view. So all this can be possibilities, but what's important over here is we have to grade it accordingly. If you see this although they both are lateral views, one is an MRI and one is an X-ray, it most likely appears to be a compression type fracture involving the anterior middle column, and at least on this view the posterior ligamentous complex looks intact. But we would like to have another AP view as well, just to see whether the spinous processes are rotated or not, or whether there is any translation of one vertebra over the another as well or not. On MRI you can appreciate there's definitely injury and fracture of this vertebra, leading to some degree of the canal compromise as well. There's a retropulsion of these fragments into the spinal canal. Or it could be high energy fractures of fracture dislocation. Usually this is what happens in the trauma due to major injury sustained in a motor vehicle collision, falls, or diving from heights. And in sporting activities, horse riding and collapsed building, this is what usually results in fracture dislocations. Are type C of injuries, in which there is actually translation and rotational injury as well of the vertebra, leading to complete spinal cord injury. Now coming to the compression type injuries, which was the first one. This is actually the failure of the vertebral body under axial loading. When something is going to compress over another, one vertebra may get compressed or crushed under the load of another vertebra. It may be due to simple because the bone is so weak that its the own weight is actually acting as a crushing force, but it could be due to traumatic injury as well. Now if this happens, this is usually this type of wedge type of a fracture which can be appreciated over here, and you can also appreciate the bones are relatively very weak. This may be a compression type of fracture in osteoporotic bone as well. There may be is associated with wedging of the anterior body with the localized kyphosis. If you see the angle over here, probably there is increased kyphotic angle at the lumbar spine. And if you see, this is L5, L4, this is the L3 level. Normally the lumbar spine is lordotic, but instead over here due to compression it has become kyphotic. With increased forces on the posterior body wall, which may eventually lead to, because anterior column once collapses, there is increased stress to the middle as well as the posterior column, and eventually middle column may fail, also collapse under the pressure, and eventually the fragments are retropulsed into the spinal canal, which, as I told you, the retropulsion of the fragments into the canal and interpedicular widening may occur, which is actually visible on the AP view when you see the interpedicular distance is actually increased with compression type of a fracture. Occasionally, there is a lateral compression which may occur as well. Actually, the compression which is, if it occurs in the sagittal plane, which is the anterior posterior plane, there is definite retropulsion back into the spinal canal. But if the compression occurs in mediolateral plane and the coronal plane, this usually results in lateral compression with local scoliotic deformity. Disruption of posterior tension band with instability may or may not occur, but usually it does occur at times as well. And what is posterior tension band? The posterior ligamentous complex forms the posterior tension band. You have to remember that they are actually the tension band force which actually helps to move one vertebra as relative to the another. This could be a type A or type B injury. Type A is purely compression type injury. Type B is actually compression with translation injury or distraction injury as well, in which there is actually anterior compression and distraction of one vertebra over another, which may be associated with simply ligamentous injury, due to which the one ligaments are torn, posterior ligamentous complex is damaged, and one vertebra without even a fracture just translates over another. Or it could be osseous ligamentous, in which there is osseous fracture as well, along with the ligamentous disruption, and as a result one vertebra is sliding over another. As I told you, it's due to the posterior ligamentous complex create a posterior tension band, and it's actually holds the two vertebrae together so that they move relative to each other in a synchronized fashion. Now coming to the rotational and translational injury. Whenever there is a rotational translational injury, it was called as type C injury. This may be due to shear or torsional forces, and injuries are usually unstable, mostly are unstable, and may be associated with neurological compromise as well. Pedicle spinous process malalignment is clearly visible on AP view. When there is actually a translation in the coronal plane, this usually can be appreciated in AP view, but if there is translation in the sagittal plane, that is actually visible on the lateral view. Facet joints, if they are not fractured, they're usually dislocated and usually associated with bilateral facet joint dislocation. And these are all called as type C injuries, where there is translation as well as rotational element along with the spinal cord fracture. Now coming to the distraction type injuries, as we will be discussing the flexion distraction mainly, and type B injuries over here, these are also called as chance fracture or seat belt injury. As I told you, the most common mechanism of thoracolumbar spine is at the thoracolumbar junction. Why? Because of inherent instability, because one segment is more mobile as compared to the other segment. So what happens is the patient is sitting in the car with the seat belt in place. Suddenly there's an accident and decelerating force occurs on it. The patient is pushed forward. With the pushing forward, the thoracic spine moves more rapidly as it is more mobile and goes forward. With thoracic spine is going forward, the lumbar spine, which is more rigid and less mobile, actually goes forward, but with to a lesser degree. As a result, The increased distraction of thoracic spine over the lumbar spine leads to this distraction type or flexion distraction type of an injury called as chance fracture or seat belt fracture. This is, as I told you, the mechanism spinal flexion with the distraction movement, especially when there's a decelerating injury. And as you know, the seat belt has two components. One is the thoracic component and another the abdominal component. The abdominal component actually holding the lumbar spine further along with the lumbar abdominal organs. As a result, there is an overall increased movement of thoracic spine as compared to the lumbar spine, leading to this type of a flexion distraction injury. Disruption may be bony, as with osteoligamentous or simple ligamentous as well, and there could be a combination of both as well. 50% is associated with intra-abdominal injuries, because usually there is definitely soft tissue as well as visceral organ injury of the abdomen as well. Unstable injuries, why they are unstable? Because there is posterior ligamentous complex disruption. They are mostly unstable, rarely they are stable, considered stable, and they have to be evaluated very clearly whether they're stable or unstable. Now, examination, when you're examining a patient with thoracolumbar spine injury, what you have to look for is usually the telltale signs of the back pain, falling in injury, showing sign of bruising and tenderness. There could be hematoma over there as well. Head and neck injuries, chest injuries, pelvic fractures, other multiple organ injuries may be present as well. Especially if there is a chance fracture, a seat belt fracture, this is associated with abdominal injuries or blunt abdominal trauma. And when the patient has had an RTA, there may be associated pelvic injuries. There may be associated femur fractures as well. So you have to evaluate patient as a whole as per ATLS guidelines. There may be associated chest injuries as well, because one seat belt component of the seat belt is also the chest restraint as well. Once the patient is vitally stable, this primary survey has been done and the neurological evaluation is done, then we have to go for full neurological evaluation of the spinal cord, whether there is a complete spinal cord injury or incomplete spinal cord injury. And to evaluate that, we have to go, once the patient has out of danger, hemodynamically stable, then we evaluate the spinal cord injury, whether it is complete or incomplete spinal cord injury. And how do we evaluate it? Start with the x-rays, simple as AP and lateral films. Maybe oblique films may be required as well, but sometimes when especially we are suspecting either the spinous process or transverse process fracture, then may be required, but not always. But most important component is the CT and the MRI. Whether you need an MRI or not, then again that's also debatable, because if it's complete spinal cord injury, and then probably MRI may be indicated or even may not be indicated, because you know it's going to be once the patient comes out of the spinal shock, then may require further evaluation whether to proceed with some fixation or not. As I told you, it's X-rays, it's CT and MRI. Now, once we have diagnosed it, we diagnosed it on the basis whether it's type A injury, type B injury, or type C injury, whether there's only compression, there's distraction flexion, or there's rotational and shear mechanism is present as well. Then that treatment depends on the type of anatomical disruption. That is A, B, C type injury. What type of injury is there? Whether the injury is stable or unstable. Usually type A injuries are mostly stable. B and C injuries are mostly unstable and require fixation. Whether there is neurological involvement or not, because neurological involvement and canal compromise is almost an absolute indication for surgery and requires fixation, then you also need to decompress the spinal cord canal, where either directly or indirectly as well. And then presence or absence of concomitant injuries as well, whether they're associated abdominal or visceral organ injuries or not as well, or there is injuries associated with like pelvic injury, it's present as the pelvic fracture, acetabular fracture is present or not. There may be associated when the spine, there may be fracture of thoracolumbar spine, there may be associated with fracture somewhere up in the spine as well, in the cervicothoracic region or cervical region as well. Then depending upon the situation, you may need to fix other fractures, and you can manage conservatively this thoracolumbar fracture. So it depends what type of a fracture it is, whether it's stable or not, whether there is associated injury or not, and whether there is neurological compromise or not. You decide whether to go for conservative treatment or to go for fixation. And then once you decide for fixation, whether to go for posterior alone or combined anterior as well posterior approach, that depends upon the geometry of the fracture. In this section, we have briefly gone through the mechanisms and pathophysiology of the thoracolumbar spinal injury. The mechanisms mainly include the axial loading and compression injury, which includes called as type A injury. This may be associated with flexion distraction injury, in which there is compression as well as distraction of the due to disruption of the posterior ligamentous complex, which is termed as type B injuries. This could be isolated ligamentous or osteoligamentous. Then there is a type C injury, in which there is rotational as well as translational injury of the spinal cord. Mostly type B and C are unstable and require fixation, while mostly the type A are these compression injuries are stable and usually can be managed conservatively. Thank you very much. Keep watching sqadia.com.